Let's talk about some eye anatomy. Now in this video I'm going to go over some anatomy of the front part of the eye and some of the microscopic stuff you're going to see, and I'm also going to go over some CT scans and go over the muscles of the eye, the bones of the eye, and read some of this stuff for you. So let's go ahead and get started with the basics, which would be the external exam. Now the first thing you're going to see in an eye exam is the conjunctiva, and the conjunctiva is just a layer of tissue that sits on top of the eye, and it's clear, and it sits right here on the white part of the eye. Now the conjunctiva is not white, it's clear. You're seeing the white of the eye underneath, and the conjunctiva is a layer of tissue that protects the eye and also creates a surface underneath. It actually loops underneath the inside of the eyelid and forms the back of the eyelids here, and explains why if you say have a contact lens that slips down, why it doesn't go behind your eyeball. It gets trapped by the conjunctiva here. And people that get conjunctivitis get a infection of this layer of tissue. Now the conjunctiva actually inserts right here at the limbus where it becomes clear cornea, and that's the front of the eye, of course. And if we take a picture of this, we see here's the limbus, and the conjunctiva is a thin layer of tissue here, and there's actually little blood vessels running through the conjunctiva. And when you get, say, a conjunctivitis, these blood vessels will dilate and get very red, and that's why your eyelid's pink. Now the eyelids are actually formed by, you could really break it down into two layers. There's an anterior lamella, which has the muscles and things like that, and there's a posterior lamella, which is formed by the tarsal plate. This tarsal plate is a layer of tissue that's somewhat tough, and gives the eyelids its shape and things like that. And some of the muscles that open and close the eye insert on this tarsal plate. Inside the tarsal plate are the meibomian glands. I've actually drawn this wrong. The glands actually sit inside of the plate, and they squirt oil through little pores right here at the base of the eyelids into the tear film. And if we take a photo, we can see little pores here right along the edge of the tear of the eyelids, and oil is squirted out these pores into the tears, and this oil is real important to keep the tears from evaporating too quickly. A chalazion can occur if one of those little pores gets clogged up. You can get a backflow of lipid into the gland, and you can get a granulomatous reaction. It's not an infection, but it is something we see quite commonly in ophthalmology. It's one of the bread and butter things that we see. And people will have a hard lump on their eyelid. It's not tender, it's not infected, but they usually won't go away on their own, and we have to actually flip the eyelid over and use a little scalpel to incise and drain these things. Now that's much different than a stye, which is more like a pimple. It's a little small localized infection, which is usually self-limited, typically red and very tender. The two main eyelid muscles you need to know about are the orbicularis, and these are the muscles that are formed in a circular pattern around the eyes and actually close the eye, and it's controlled by cranial nerve 7. So if you have, say, a Bell's palsy where you lose the facial muscles on this side, these patients have a hard time closing their eye, and that can create a lot of exposure problems. The other muscle is the levator palpebrae, which is controlled by cranial nerve 3, and this muscle is actually a ribbon that attaches to the top of the tarsal plate that we saw before, and it pulls the eye open. And if you have a cranial nerve 3 palsy, then these people have a ptotic eyelid, a very low eye. The mnemonic I use to remember what nerve does what is cranial nerve 3 opens the eye, and you can think of that like a 3, like a pillar, and cranial nerve 7 closes the eye, and you can think of that like a fish hook. The lacrimal system controls the tears and the tear drainage. Now the majority of tears are actually produced by accessory glands up in the conj, up in the fornix usually, but a lot of our reflex tearing is produced by the lacrimal gland up here in the corner, which squirts tears into the tear film here. The tears then are drained out of small little punctum down a canalicular system into a sac, and then down a nasolacrimal duct where it drains into the inferior meatus, which is underneath the inferior turbinate. Here's a video just to show you what this punctum look like. They're very small, and you've got two of them, one on the bottom, one on top, And here's a close-up video of one of them. Here's another patient. This one's a little bit more obvious. Now, people have different size punctum. Sometimes they don't have punctum. People who have chronic dry eyes, we can actually put a little plug inside of this thing, and that way their tears don't drain too quickly, and that seems to alleviate a lot of their symptoms. Here's a patient who had the opposite. She came in complaining of tearing, and under exam you can see that she has an eyelash that's actually stuck in the punctum on that side. So we just pulled that out and her symptoms went away. Here's an axial CT. I wanted to show you this because the tears from the eye drain into the nose, and they drain down the nasolacrimal duct. And if we start up here at the eye and move our way down, this is right here medially, and follow this down, you can actually see a little hole here, and that's the nasolacrimal duct. Just a little circle, and as you go down it drains into the nose, and here it is draining into the nose. And you can imagine if someone has a lot of facial fractures or some type of dysgenesis of the bones, that this could be broken, and that can cause a lot of problems with tearing. If you do have a lid laceration, the most worrisome area really is medially, because you can cut right through the canalicular structures, and this needs to be repaired surgically, where we'll actually run a tube through the system and leave that tube there for while everything heals up around it in order to keep this drainage patent. But let's go on to the globe, because that's what we're going to be talking about for the most part. The outside of the eyeball is created by the sclera, and this is a type 1 collagen layer, very thick, very tough. Well, actually it's not that thick. Everything's relative, because the eye is only about 24 millimeters long, which is about an inch. But the sclera is pretty tough. The front of the eye is formed by the cornea, and this is the clear area. Now, the interesting thing here is that the sclera and the cornea are both made by the same type of collagen. And the reason the cornea is clear is because, one, it's organized a little bit better as far as how the collagen is arranged, but more importantly, the cornea is relatively dehydrated compared to the sclera. And I'm going to go into that a little bit more in a couple of slides. In the back of the eye, the sclera forms the optic sheath going back to the brain. Now, the cornea has 5 layers you need to know about. On the surface is the epithelium. This is several cell layers thick, and this is constantly regrowing, and people have abrasions and things like that. Very painful, but it heals very quickly. Underneath the epithelium is a Bowman's layer, and then a stroma, and the stroma is the main body of the cornea. It's formed by that collagen, and if you have a perforation into the stroma, you can actually get scarring. As we go down, we have Descemet's membrane, which is actually a basement membrane to the endothelium. Now, the endothelial layer is probably the most important layer in the cornea, because it's only one cell layer thick, and that's how I've drawn it here. And these cells, they don't duplicate. If you kill off these cells, the other ones just get bigger to take up its place. And so you're born with a certain number of endothelial cells, and they decrease over time. This layer is very important because it constantly pumps water out of the stroma back into the eye, and it keeps the cornea relatively dehydrated. Now, if you have a problem with that layer, then you're going to get some swelling of the cornea. I'm going to show you that in a second. What this picture shows is a slit lamp photograph of the cornea. This patient has some dendritic ulcers here, which are a little out of focus and probably very difficult for you to see. But what I did want to show you is that when you shoot a slit of light into the eye, you can actually get a sense of how deep in the cornea things are. Now, this is the front of the cornea, this is the stroma, and this is the back of the cornea. And when we look at a lesion like this, it's mostly on the front, mostly in the epithelial layer. Let's take a better look here. This is shooting a light beam the other way. Here's the front of the cornea, here's the stroma, and this is probably the back of the cornea here. And of course, this is the iris underneath. But you can see here a big circle, which appears to be in the deepest layer. This is just a little shock wave in the endothelial layer from an object bouncing off the front of the eyeball. But what I wanted to show you here is just that you can use your slit beam to actually visualize each layer of the cornea. And you can also use it to gauge how thick the cornea is. Now, this is a patient with a corneal ulcer, And you can see here that this slip beam going through this thing gets very thin here, and that's because the cornea, the stroma, has thinned out quite a bit and is actually on the verge of perforating. In fact, this cornea is so thin here that right in the middle of this ulcer it got clear, and it's not clear because it's healthy, it's clear because it's so thin it's about to perforate. Now, if you have a break in your endothelial layer, which happens sometimes with certain ectatic disorders, or even with trauma, or if you have, let's say, very high pressure inside the eye, then you can have water actually push into the corneal stroma, and when that happens, the eye will turn white. And so this cornea is no longer clear, it's white, just like the sclera out here. Now, when I first started studying the eye, for some reason I thought there were two chambers in the eye. There's the back and the front, but there's actually three chambers. There's the vitreous chamber in the back, a posterior chamber sort of in the middle. This is between the lens and the back of the iris, and then there's an anterior chamber in the front. Now, the vitreous chamber in the back, the posterior chamber, is filled with vitreous humor, which is a jelly-like fluid, and when you're born it has the consistency of jello. It kind of wobbles, it's firm, but as you age you get little pockets of liquefaction where it kind of liquefies, and over time you can get so much that it kind of pulls off the back of the retina, and this is what we call a posterior vitreous detachment. Very common, almost always harmless, but it's one of those things that can create floaters, and people complain of seeing stuff floating around. It's usually stuff on the back surface of this vitreous. Now, this is a video showing what that looks like in real life. I'm going to decode it before I start it, though. This is the front of the eye, so this is the upper eyelid. This is the surface of the cornea, and this is the lower eyelid. This is the anterior chamber, just a space of fluid, and here's the front of the lens, and this is the back of the lens right here. And if you look behind the lens, what's back there? Well, that's the vitreous jelly, and there's some stuff here. So let's go ahead and play it. And you can see that behind the lens there's like almost like a sheet, and what that is the vitreous has kind of collapsed forward, and what you're seeing is the back sheet. So behind that is a bunch of liquefaction, and in front of that is the actual vitreous itself. Very common to see this on exam. Let's go ahead and take a look at the rest of the eye. There is, of course, the iris. That's the colored part of the eye. The ciliary body, which is a muscular area which is actually contiguous with the iris. And the ciliary body does a couple things. One thing it does is it pulls on the lens via these little zonules, and these zonules attach to the lens to the ciliary body in a 360-degree trampoline type arrangement. And when the ciliary body contracts, it actually is a sphincter muscle, so it comes this way, and the lens zonules relax, and the lens gets rounder, and that's how you see close up. The lens itself, you can actually think of it kind of like a peanut M&M. There's a hard candy shell on the outside, the capsule. Then there's a chocolate layer, or the cortex, and then there's a peanut in the middle, and that's the nucleus. Now, when we do cataract surgery, what we do is we tear a hole in the candy shell in the front. Then we run a tool in here that acts kind of like a jackhammer and breaks up the nucleus and the cortex. And then we suck all that out with a vacuum cleaner, and then we inject a new implant inside of the capsule where it sits right here in the appropriate position. So let's take a look at a patient with a very mature cataract just to see some of this anatomy. Now, this patient's cataract has gotten so bad that the chocolate layer has liquefied and become kind of white and milky. The nut has hardened and turned kind of brown and sunk to the bottom of the milk, and the hard candy shell, the capsule on the outside, is still intact. We know it's intact because otherwise this whole eye would be filled with white stuff, but it's not. It's all self-contained right there. Now, the zonules are real important for keeping the lens in a proper position. This patient had a trauma, and his lens dislocated. All the zonules out to the side here ripped, and the lens has fallen backwards somewhat. And you see the stuff floating here? It kind of looks like jelly or jello kind of floating there. Well, that's vitreous from behind the lens, which is kind of protruded and come around in front of the lens into the front part of the eye, and that's never a good thing. Moving back into the eye, this is a photograph, and in this photograph it's somewhat out of focus, but what you can see here is a round thing that's somewhat pink and somewhat yellowish, but if we zoom in we can actually see that's the retina, and that was the optic nerve we were seeing. And when you look at a retina, The main things to look for are the macula. That's the central part of your vision, the area that's slightly hyperpigmented. In the center of that is the fovea, and that's the area responsible for the majority of central vision, and has the highest number of cones than anywhere else in the retina. And of course, there's the optic disc, and there's a bunch of vessels and things like that coming off. But if we look at a real photograph, we can see the optic nerve is here. The veins and arteries are coming off. The veins are the darker ones; they're slightly larger, and the arteries are the smaller, lighter-colored ones. There's a small cup right here in the middle of this disc, and when we look at glaucoma patients, we're always talking about their cup to disc ratio, and I'll go into that in a little bit more detail in other chapters. Here's the macula. That's the entire pigmented area, and there's a little divot here which casts kind of a funny reflex, which is the fovea, and that's the part that's important for central vision. Now, the retina looks red in part just because of some pigment cells back there, but it's also in part because of the choroid. And the choroid is a bed of vasculature, blood vessels, that support the retina. Now, the retina is one of the most metabolically active tissues in the entire body, so you can imagine it needs a rich blood supply to give it nourishment and also to take waste products away. Now, a lot of anatomy books and people will try to teach you the multiple layers of the retina. I don't think that's real important at this point. Just realize that there's a layer of photoreceptors that's actually quite deep. Now, when light comes into the eye, it has to go through the majority of the retina because the retina is actually clear. It goes through a bunch of cells and it hits the photoreceptors. From there, the signal is sent back up into the ganglion nerves, and these are the nerves that actually transmit the signal back down the optic nerve to the brain. And of course, there's the choroid underneath that's supporting this retina. Now, the outer third of the retina, and by outer I mean closer down here, this would be inner. The outer third or so of the retina is supplied by the choroid blood supply. And you can imagine that if someone has a retinal detachment, that the photoreceptors can die quite quickly if they're not attached to this choroid because the detachment happens between these things. Moving on, the eye has a bunch of muscles tethered to it, and these can be quite confusing, so I'm going to break them down into two groups. The first group is a series of 4 muscles that attach to the sclera of the eye and run back to the back of the orbital apex. And these are the rectus muscles, and there's a superior, an inferior, a lateral, and a medial, which is a nice naming convention. And they attach back here at the annulus of Zinn, which somewhat encircles the optic nerve going back to the brain. There's another set of muscles which are more confusing. There's the superior oblique, which runs along the medial wall and inserts back here, and then there's an inferior oblique, which I've actually drawn incorrectly. It doesn't really attach on a pulley or anything. It attaches to the orbital floor. But these muscles are more important for turning the eye in more of a twisting motion. And these are the oblique muscles. So the rectus muscles basically do the cardinal directions. I didn't actually draw these cardinal directions entirely true, but for now we'll just think of it this way. But let's go ahead and look at a couple of CT scans and we can actually see these muscles. So this is below the eye, and I'm going to move up towards the eye. And as I do so, there are the globes, and we can see here some muscles. This is the medial rectus, and here is the lateral rectus. And of course here is the optic nerve going back to the brain. As we move up, let's see if we can see the superior rectus. Well, maybe this is what that is. It's hard to tell, but one thing you can see here, which is kind of neat, is that there's a little muscle running along this medial wall, which seems to turn directions and insert onto the eye. And this is probably the superior oblique inserting onto the globe itself. So if we take a look with some coronals, of course here are eyes. This patient's looking down. You can tell that because the lenses are pointing in the wrong direction, but that's okay. And as we move back, we can start to see some of the muscles. Here they are. Here's the superior and the inferior rectus, the medial rectus and the lateral rectus. This is probably the optic nerve right here. And this little muscle here is most likely the superior oblique. One of the interesting things here is that you can sort of see something connecting the rectus muscles together. There's a little thin layer of tissue here, and it runs down here, and basically the rectus muscles are all connected by an intramuscular septum, which connects them like a cone. And so you can think of the eyeball like an ice cream, and it sits in a muscle cone. And this cone is real important because sometimes we need to inject anesthesia back there, and also people can have retrobulbar bleeds and things like that, and that becomes an issue because it's a little compartment. You can have little compartment syndromes and things like that back there. So let's move on. The orbital walls. Now, 7 bones make up the orbital walls, and don't be too worried about that because they're not that hard. The first 3 of them you can kind of figure out from your surrounding anatomy. For example, the roof of the orbit is an extension of the frontal bone. Over here is an extension of the zygomatic, and down here on the floor is the maxillary, so that's not too bad. These other 3 are a little bit harder, but let's go through them. The ethmoid, that forms the medial wall. Now the ethmoid is actually the thinnest of the orbital bones, and it's also called the lamina propria, or paper wall, because it has these very thin air cells in them, which are they break easy. Now, this bone is actually not the one that breaks the most often. The maxillary bone seems to be the one that breaks the most often with trauma. You get these floor fractures and stuff herniates down into the maxillary sinus. But this ethmoid is very thin, and people with real bad sinus infection can have sinus infections track and actually break through this bone into the orbit, and that's not a good thing. Of course, the lacrimal bone is kind of small, but that's where the nasolacrimal duct goes down into the nose. And the sphenoid is a somewhat complex-shaped bone when you remove it from the skull, but the greater wing forms the majority of the back here, and then there's actually a lesser wing back here that the optic nerve travels through. Finally, there's a palatine bone, a little one back here, but let's not worry about that. Here, let's go ahead and look at some CT scans again. As we move up, there's a nasolacrimal duct. We're moving up towards the eye, and here we are. Here's the globes. And of course here's a lateral wall, the medial walls formed by the ethmoid bones with a bunch of ethmoid sinuses and things like that. And moving up towards the roof, we can see the frontal sinuses. When you're looking at bones and bone fractures, it's really best to get a coronal because you'll get better view here. And as we move forward, looks like here's our frontal sinus, and here's our maxillary sinuses. And we can see our medial walls, our lateral walls real good. Our floors looking good here. There's no floor fracture breaking down into the sinus. And as we move back, another one of our landmarks are our clinoids, and of course we've got our sphenoid stuff back here. If we move back forward again, there's our sphenoid sinus in the back. But it's one of those things that the more you're exposed to it, the more it'll make sense and come together. So let's summarize. The levator muscle opens the eye. It's controlled by cranial nerve 3. People with palsies and things like that, so I'll often have droopy eyelids, and we'll do levator muscle surgery. The cornea is clear because it is relatively dehydrated compared to the sclera, and the clarity is dependent upon the endothelial layer of the cornea, which is a continuous pump. The uvea, I didn't define that before, but you should know about it, is a combination of the iris, the ciliary body, and the choroid. They're all related to each other during embryogenesis, but that's what we call the uvea. People get uveitis, which is a inflammatory condition, but we'll go over that in other chapters. If you have a lid margin laceration, if it's medial, you got to worry about hitting the canalicular system and having tear problems. The lens has 3 layers like a peanut M&M. When we do cataract surgery, we leave the outer candy shell, but we take out everything in the middle and inject a new implant inside that shell. The retina actually has 2 blood supplies. There's the choroid from below, and there's actually a superficial blood supply that runs through those blood vessels that you saw in those fundus photographs. Rectus muscles, there's lots of them. They all insert on the annulus of Zinn, and you can see these things on the CT scan. When you talk about the bones of the orbit, the floor fractures are the most common, even though the ethmoid bone is the thinnest, and the ethmoid is often involved with sinus disease. If you'd like to see more of these videos or read the book that these videos are coming from, drop by opthobook.com and you can download these things for free. And if you are going to read the book, I recommend downloading the PDF. It looks much better than the actual web version, and it's much easier to read this thing if you print it. So that's probably the way I would do it. Thanks for watching.